Hi, my name is Dr. Renaud, and today I'm going to be going over the treatment of osteoporosis and fractures for your gerontology lecture. Before we get started, I want to identify what the learning objectives are for this lecture. I would like for you to be able to define what osteoporosis is as well as what fractures are, describe the pathophysiology of osteoporosis and fractures, identify complications of osteoporosis, list the diagnostic criteria for osteoporosis, and discuss non-pharmacological and pharmacological therapies that can be utilized for treating osteoporosis. Next, I want to go over what exactly osteoporosis is, and if you look at the pictures, this will kind of help it make sense, but the root words of osteoporosis literally mean porous bone, like it has holes in it. So look at the picture on the right. You'll see the top is normal bone and the bottom is osteoporotic bone. And the top picture, the normal bone, looks very filled in. There aren't a lot of gaps and holes. Whereas the osteoporotic bone on the bottom has a lot of gaps and holes. And so it makes sense then that a patient who has osteoporosis is going to have some increased bone fragility just because it's not as dense or as filled in. Osteoporosis tends to be an asymptomatic skeletal disorder, meaning that people may not even know that they have it until they have a fracture. It could be diagnosed with a screening, possibly, but there is a risk that people will not even know they have it until after they get injured. I want you to know that when a patient has low bone mineral density, it does cause an increased risk of fractures. And also, the cause of osteoporosis, there are a few things that can make it a problem. Either the body is losing too much bone, so it's like the bone is breaking down too much, or maybe the body is just not making enough bone, so even though it's breaking down normally, if you're not making enough bone, it's not in balance, right? Or it could be a combination of both. But the end result tends to be that that bone becomes weak and then breaks when there's a fall, some kind of traumatic event. Even sometimes patients might have some type of a fracture or a bone break simply from sneezing or coughing or having a minor bump. And we'll get into that later. That's called a fragility fracture. I want you to know that elderly patients are more likely to suffer from osteoporosis than younger patients. It is more common in elderly patients, but that doesn't mean that younger patients can't have it.
Bone is a dynamic tissue that is continually being built, broken down, and rebuilt in a process called bone remodeling. Bone tissue is broken down and resorbed by multinucleated cells known as osteoclasts. These cells are derived from monocytes which originate within bone marrow. Osteoclasts play an important role in liberating minerals and other molecules stored within the bone matrix. Bone tissue serves as a repository for vital minerals including calcium phosphate and various biologically active molecules, such as growth factors. The release of calcium from the bone can play a role in maintaining its homeostasis within the body. The cells responsible for building new bone tissue are known as osteoblasts. Osteoblasts are thought to be derived from cells found to be associated with blood vessels. Once active, they start to produce the organic component of bone, osteoid, which is predominantly made of collagen. Minerals start to crystallize around the collagen scaffold to form hydroxyapatite, the major inorganic constituent of bone, which contains calcium phosphate. Bone mineral density, or BMD, can be used to estimate the strength of bone and to assess the risk of fracture. As osteoblasts form new bone tissue, many become embedded within the matrix and differentiate into osteocytes. The structure, composition, and cellular processes that occur within bone allow it to simultaneously serve as a calcium reservoir. while providing structural support for the vital organs and for locomotion.
So now I want to discuss how exactly does osteoporosis occur. And after we've seen that video, this should make a little bit more sense. But note how the normal bone looks on the left and how the osteoporotic bone looks on the right. You'll see that the image on the left has an outer layer called cortical bone, and you'll see it's nice and thick. And you'll also see that the trabecular bone inside of that layer is also pretty nice and thick, and it's a little more filled in. Let's look at the picture on the right now. Do you see how the thin cortical bone is there? There's not a nice layer cushioning that trabecular bone. And on top of that, the trabecular bone itself is not as dense and it's thinner. And I want you to know a little bit about cortical bone. This will kind of help make sense. Cortical bone is actually comprising about 80% of your skeleton, and usually you can find it in long bones like the hip or forearm, whereas the trabecular bone, that spongy looking material, is usually found in vertebra and at the ends of long bones. And it has a honeycomb shape that you can kind of see in the picture, and that helps increase the rate of bone turnover. So if you increase your bone turnover rate, that means that that trabecular bone forms and breaks down more frequently than cortical bone will. The image on the right, like I said, shows someone with osteoporosis, and you'll see again that thin layer of cortical bone and that thin trabecular bone. And as a result, that thin bone does increase the susceptibility to fractures and bone loss. And remember, again, that osteoporosis affects the body because either the body is losing bone tissue too quickly or not building it quickly enough, or a combination. But that's basically the process of how osteoporosis differs from normal bone building processes. Now we can go over some of the etiology and risk factors associated with osteoporosis and even fractures. Notice that there are many different factors that can contribute to osteoporosis. And so I've tried to make this list a little bit more based on common things that you'll tend to see. So notice that genetic component is a huge one, and genetic factors can cause up to 80% variability in peak bone mass. And that basically means that if you have a patient who maybe doesn't have very strong peak bone mass due to genetics, it doesn't really matter what that patient's going to do. They're always going to kind of be at a disadvantage because they just don't have the genetic makeup to support a lot of bone mass. So that's definitely a factor. Also, you'll see age greater than 50 years. And also, I mentioned body weight here, and I want to make this clear to you that body weight less than 127 pounds is related to someone at a normal height. If you have someone who's short, 127 pounds won't seem like it's the same level of fragility as if you have a very tall person or even a normal height person at that weight. The bones in a shorter person at that weight then are going to be a little bit stronger, right? Because you've got a little bit more weight to support you. But keep in mind that while that body weight is considered to be a risk factor, you have to account for whether or not the person is tall, normal height, or short, because the shorter you are, it's kind of expected that you weigh a little bit less just because of BMI. Also, I want to mention smoking and alcohol consumption because those are actually preventable risk factors. We know that smoking is a problem. They've actually linked cadmium levels inside of tobacco products to osteoporosis because cadmium can increase the metabolism of bone tissue, and if you're increasing the metabolism of bone tissue, then you're breaking down the bone faster. Also, we've got alcohol. And make sure when you talk to a patient about alcohol consumption that you make it very clear that if they're drinking 3 or more drinks a day, they're at an increased risk of osteoporosis. And that's actually a multifaceted reason. Alcohol can increase your risk of falls because it can make you maybe a little bit less cognitively aware and just tired, so you're going to trip a little bit maybe. Also, alcohol can cause a calcium deficiency, and it can cause chronic liver disease. And believe it or not, when you have chronic liver disease, you're also going to have a deficiency potentially in your vitamin D levels. So alcohol can affect a whole lot of things in your body, and that can all lead to osteoporosis. For medications, there are a lot of different classes. Some of the notable ones include anticonvulsants, glucocorticoids, proton pump inhibitors, and hypnotics. And I want to go over the mechanism of what exactly these medications do to the bone levels and mineral levels in the body. Anticonvulsants will decrease your bone mineral density, and they can reduce vitamin D levels. And remember, vitamin D is important because it can help with calcium absorption. Glucocorticoids also decrease bone mineral density, and at the same time, they increase bone resorption, which basically means that your osteoclasts are going to be breaking down some of that bone. So you have a lower bone mineral density, and you're also increasing the breakdown of bone. And I want to make it clear that with a steroid, you need to be paying attention to the prednisone equivalent, because the studies have shown that if you're at 5 milligrams of a prednisone equivalent for over 3 months, that's when steroids become concerning for osteoporosis risk. So if you do see someone on a steroid, you need to compare it to this prednisone equivalent to see whether the dose of their steroid would be a high-risk dose for osteoporosis. Proton pump inhibitors can decrease bone mineral density. Antidepressants like SSRIs, those can decrease bone mineral density and osteoblast activity. And so if you don't have osteoblast activity, you're unable to form bone. And of course, opioids, hypnotics, anything like that, those can lead to falls because patients can become sedated, or maybe they just aren't able to keep as good of control when they're walking, and their motor function declines a little bit. Other risk factors will include these things. Notice the first one I have up there is fractures and falls. If you have a patient who's had prior fractures and falls, they're automatically at an elevated risk. Either that means their bones might already be kind of weak, or if they're falling a lot, then they just are more likely to have a traumatic event in the future because they keep falling. And I've also mentioned sedentary lifestyle because if you remember what we were talking about with body weight, when your body is used to having some pressure on it, the bones adapt to that. So you can have more dense bones to make up for the fact that you're putting your body through a lot and your body has to accommodate to those changes. However, if you are looking at maybe a patient who lies in bed all day, then they're not putting that same stress and weight on their bones. So their bones are not going to continue to become stronger because there's really no need. If you're lying in bed, your body doesn't see the need to increase your bone mineral density. So patients who have a sedentary lifestyle tend to have weaker bones than people who move around, because when you're moving around, you're putting pressure on your bones, stress on your bones, and that will increase the strength of your bones in an attempt to adapt to that. I also mentioned autoimmune conditions, because of course we already know a lot of patients who have autoimmune conditions use steroids. So we come into that issue where steroids can affect the risk of bone mineral density being decreased. But also patients who have maybe a malabsorption issue like irritable bowel disease, those patients are going to have trouble absorbing nutrients from their diet simply because of their autoimmune condition. And that means maybe they're not going to be absorbing enough vitamin D or calcium. And also, your patients should know about making sure that they're eating foods that are high in calcium and vitamin D. We'll get into the exact levels they should be getting later, but if they're not eating a proper balanced diet, then the bone isn't going to have what it needs to become stronger. For secondary causes, I want you to pay attention to hyperthyroidism. Hyperthyroidism actually causes increased bone remodeling, and remember, that's the whole process of your bone breaking down and then rebuilding. So if you're increasing bone remodeling, you're potentially going to cause osteoporosis because it's just going to be remodeling too quickly. Also, I've mentioned hyperparathyroidism. That can result because if the parathyroid's increasing calcium levels in the blood, That means calcium is not going to be stored in the bones. It's going to kind of be leached out into the body, and then that increases serum calcium, but now your bones don't have as much calcium. And I mentioned early menopause is another thing. And when I say early menopause, I'm talking about people who enter menopause before the age of 45. Here is our first lecture question. And remember, you guys are going to be answering this as a group, writing it down, and then making sure that you're explaining your rationale and citing it. The question is, which of Mrs. Penny's medications could be contributing to her fracture risk and why? Your second question to answer in your teams is, what non-medication risk factors does Mrs. Penny have for osteoporosis? Here I'm going to discuss the fractures that you might see in osteoporosis patients, and most of the time it can be expected that if a patient has a fracture, there's some kind of very clear precipitating event, like a fall or some type of traumatic event, maybe blunt force trauma. However, some patients have a fracture when you wouldn't even expect that there is a precipitating event. You don't expect that if you sneeze or cough that you're going to have a fracture, but some patients actually do. And so that's called a fragility fracture. And that is called that way because if a patient's bones are fragile enough, it doesn't really matter what they're doing. Any type of movement could cause a spontaneous fracture. So I've listed some common fractures that you might see in patients with osteoporosis, and you've probably heard of most of them. The one I think you might not have heard of is a collis fracture, and that occurs when someone, you know how when you're about to fall, sometimes you'll put your hands out to try to brace yourself. When people do that, sometimes when they hit the ground, they end up fracturing their wrist. Specifically, the distal radius bone will bend backwards, and this x-ray shows that. You can see that there's a break. There's a line in the bone that's very clearly a break. And so that fracture can occur in the wrist. And remember that your humerus is your elbow, so sometimes people will fracture their elbows. Your third question that I want you to answer for me as a team is, what non-pharmacological recommendations would you make for improving Mrs. Penny's osteoporosis and fracture risk? Let's discuss why osteoporosis is even a big deal, because sometimes people don't think it's a really serious disorder and that it doesn't have a lot of complications, but it actually does. First of all, obviously, if you're going to increase fracture risk, that's very painful, and fractures can cause a lot of other problems and debilitation. They've even found that mortality rates can increase in patients, especially after they've had a fracture. They have noticed that women have about a 12 to 20% increase in mortality after a hip fracture, and men have an even higher mortality rate than women after a fracture. And I'm going to discuss this a little bit later. Women tend to have osteoporosis more than men, but men actually die more from a fracture than women do. Another thing is pain. If you've ever broken a bone, you know it really hurts. And it hurts in general to feel like your bones can't support your weight. That doesn't feel comfortable either. And sometimes if people have a fracture and it doesn't heal properly, they can get some type of a deformity, and that can be maybe a little psychologically disturbing, knowing that your bones haven't healed properly. And also, you'll notice that these people, after they've had enough fractures, or if they are currently suffering from a fracture, they can't do things by themselves as easily. They have a decrease in their independence. And we know that sometimes when there's a decrease in independence, that can precipitate depression, and then people feel more upset because they don't want to be a burden on other people. Also, financially, osteoporosis can be problematic. It's actually expected by the year 2025 that it could cost as much as $25 billion to deal with the problems that happen due to osteoporosis. I have some demographic and epidemiological data for you. It's expected that about 10.2 million Americans currently have osteoporosis, but remember, osteoporosis is only one thing. That's not including all the Americans who potentially have low bone mineral density, which may eventually turn into osteoporosis. And they've estimated that approximately 43.4 million Americans have low bone mass. So even though they don't technically have osteoporosis right now, it could develop later on. So it's still pretty widespread. Also, all ethnicities can be affected by osteoporosis. What I've listed here, and I want to be very clear, the highest fragility fracture rate occurs in Caucasian and Hispanic women. Now, there are, like I said, any ethnicity can get osteoporosis, and I want to make sure that even though it's maybe discussed on the Osteoporosis Foundation website that other ethnicities like maybe Asian populations have an elevated risk, they do have a risk of osteoporosis for sure, but in terms of fragility fracture rate, it's still higher among Caucasian and Hispanic women than other ethnicities. Also, of course, sex has a role. Like I said, females have a higher instance of osteoporosis than males. And remember, though, that males have a higher mortality rate after a fracture. And you'll notice that postmenopausal women are also at an increased risk of osteoporosis. Specifically, about 20% of them can have vertebral fractures. So when we're telling a patient about osteoporosis, we need to keep in mind that a lot of times it's asymptomatic, and that means that they need to be looking out for certain things that wouldn't normally seem like you've got osteoporosis. Sometimes elderly patients will talk about how they get a little bit shorter. That's actually a symptom of osteoporosis, a decrease in height. And sometimes they may feel pain in a certain area, but they don't even know that they've actually fractured something. You can have a fracture and not actually know it. So if they feel pain in areas like the hip or the thigh or the elbow, things like that, then it's a good idea to have it checked out because it's possible that they have actually had a fracture and they just don't know it. And since it's hard to diagnose it based on symptoms, it's recommended that that patients get screening called bone mineral density screening. And the best way to screen for bone mineral density is through dual energy X-ray absorptiometry. That's considered the most reliable screening method. And you want to tell your patients if they're going to get a DXA scan that they need to make sure that the same instrument is used each time with the same technician so that there's no variation between testing. And that will also help you see if they're actually improving. But again, if you're switching instruments and technicians, you may get a skewed result. Before I get into diagnostic criteria, I want to explain what a T-score is. A T-score is a value that represents the standard deviation of a person's bone mineral density from the average value of a young Caucasian patient of the same sex. So the lower your T-score, the lower the bone mineral density, which means the more likely it's related to osteoporosis because you're below average. And in order to diagnose osteoporosis, the T-score has to be within a certain range if we're going to use that as our only factor. If it's less than or equal to negative 2.5, that's considered osteoporosis. If it's between -1 and -2.5, we call that osteopenia, which is still problematic, but it's not technically osteoporosis. There are instances where you can diagnose osteoporosis without a T-score being in that range of less than or equal to -2.5 though. And that's if a patient has a spine or hip fragility fracture. If they're having a spontaneous fracture of the spine or hip, it is considered osteoporosis even if the T-score is normal or not quite at that threshold. Also, patients may have an osteopenia T-score, remember -1 to -2.5, but they may also have another fragility fracture at the same time. Maybe they've had a wrist fracture, elbow fracture, something like that. So if they have a fragility fracture that's not the spine or hip and an osteopenia T-score, we also consider that to be osteoporosis. And the other thing we're going to discuss, and I want to explain what a FRAX score is before I tell you it's diagnostic. The FRAX tool, the High Fracture Risk Assessment tool, is a diagnostic tool that determines your risk of having a fracture within the next 10 years. And it considers factors like age, ethnicity, sex, fragility fracture history, BMI, medications, alcohol, smoking, and other health conditions. So if your patient has a T-score that falls into the osteopenia range, but a FRAX score, remember high risk score, of greater than 20%, we also consider that to be osteoporosis as well, even though, again, that T-score is not technically the diagnostic cutoff for osteoporosis. That FRAX score makes it osteoporosis. Our next question, question number 4, I want you to use the Cockcroft-Gault equation to calculate Miss Penny's creatinine clearance. Notice that her weight is 65 kilograms, her height is 5'5", and her serum creatinine is 1.2 milligrams per deciliter. Go ahead and round your answer to the nearest tenth and make sure that you show your work on the paper that you turn in. The goals of therapy for osteoporosis, the most important thing is to prevent progression, because remember, progression can lead to fractures, and fractures can increase mortality rate in certain patients. Also, you don't want to have a fall, because a fall can cause a fracture. So it's important to make sure that patients know how to prevent falls and that they know what medications they're using that might increase their fall risk. Also, any patient who has a condition that may cause a fall should also be warned about what might precipitate a fall. You should also counsel them about how to eat a balanced diet, because a balanced diet is a great way to help improve osteoporosis. And make sure they know that if they do start a treatment regimen that they need to be adherent, they need to continue taking their medications. We'll discuss it in a little bit, but there are some medications that very quickly will reverse basically the improvements that you've made. So adherence is necessary for treating this condition. I want to make sure that we emphasize non-pharmacological therapies, because these are the most sustainable for patients who want to make an actual lifestyle improvement. These can be applicable even after medications are stopped. Smoking cessation is an obvious one. Smoking has a lot of problems associated with it, but we also know, as we've said earlier, it can increase risk of osteoporosis. So always counsel on the options that patients may have to stop smoking. Also, you should be reinforcing proper caffeine and alcohol consumption, and I want to make this clear because this might be a little confusing. The guidelines, the AACE guidelines, are geared towards treatment of osteoporosis in postmenopausal women. And in those guidelines, they recommend not exceeding 2 servings of alcohol a day. Remember, a serving of alcohol is something like 12 ounces of beer, 5 ounces of wine, 1.5 ounces of liquor. However, the guidelines do not take into account men. And technically, if you're looking strictly to prevent osteoporosis, men could have up to 3 servings of alcohol a day. But don't tell your patients, oh yeah, it's fine for you just to have 2 servings of alcohol if you're a female and 3 servings if you're a male, because other disease states don't allow you to have as much alcohol. If you have a patient who has dyslipidemia, for instance, the guidelines recommend that women not exceed 1 serving of alcohol and men not exceed 2 servings of alcohol. So if you're ever counseling a patient on alcohol, please make sure they know that this is only to prevent osteoporosis. If they have another condition like dyslipidemia, something that requires a stricter limit of alcohol consumption, you should be giving them that value. Do not give them the upper level if they have another disease that requires less alcohol intake than this one. But in general, osteoporosis, women shouldn't exceed 2 servings a day. Another thing is exercise. And when I say exercise, I'm talking about 30 minutes, moderate to vigorous activity, at least 3 to 4 days a week. And they should be doing both walking and mild strength training. Strength training is important because it can help the bones get stronger, and also anything that involves weight-bearing exercise is going to help the bones get stronger as well. So there should be a mixture of cardio and strength training, but it should involve weight-bearing as much as possible so that we can help improve some of that bone strength. You should always recommend that patients get screened. The AACE guidelines recommend that specifically postmenopausal women be screened at age 50. Another thing is physical therapy. If a patient has had a prior injury and is not able to be very active, sometimes physical therapy can make them able to move better, and they may be able to incorporate exercise as a result. Dietary intake is very important. Men and women have slightly different calcium requirements, and it also depends on their age. You'll see that men between the ages of 50 to 70, you really only need about 1,000 milligrams of calcium. But once they hit 71 and older, it's recommended that they get 1,200 milligrams. And the same goes for women. If they exceed or are the age of 50, they should be getting 1,200 milligrams. You'll notice they don't have another limit. It's basically all women 50 and older should be getting 1,200 milligrams. Another thing I've mentioned is vitamin D. And the vitamin D is also a little bit variable. And you'll notice in your textbooks, there's a little bit of controversy about it. However, both your DiPiro book and the guidelines that I have posted, they show a recommendation of about 1,000 to 2,000 units per day of vitamin D. And this is a maintenance dose. And this is recommended for any patient who actually has osteoporosis. And so for purposes of this class, we're going to go with that range of 1,000 to 2,000 units because we're dealing with patients who have osteoporosis. If we're talking about another condition or another recommendation, that value will be different. But for osteoporosis, I want you to know 1,000 to 2,000 units. And I do want to mention that the book does kind of allude to the fact that the AACE guidelines mention that they have seen patients who get 800 units of vitamin D, maybe preventing a hip fracture. But again, I'm not really worried about the prevention dietary implementation. I'm worried about what the actual dietary requirement is if you have a patient who currently has osteoporosis. So for vitamin D, go with 1,000 to 2,000 units per day. Also, make sure they know how to prevent falls. And there are many different things that you can recommend to reduce a fracture due to a fall. You can recommend that patients use things like railings or handles, stand slowly from a seated position, maybe use a shower chair or install a handle in the shower so that they can get up easier. Anchoring rugs is a big one. If you have someone slip on a rug because their foot gets caught under it, that can precipitate a fracture. That kind of goes along with another thing, using non-skid mats so that the floor is stable for them to walk on. They should walk slowly, and they should also be told that if they need some type of supportive device like a cane, they should be using it when they're walking. I've listed some pharmacological therapies here, and I've split them up based on what's recommended and what's last line. And I got this information from the 2020 AACE guidelines. So notice that the recommended therapies, there are quite a lot of them. We've got supplements, and this is very important and should always be recommended no matter what, is proper calcium and vitamin D intake. Another thing that we can use is something called an anti-resorptive therapy. So remember, that's going to basically prevent bone resorption. For medications that do that, we've got bisphosphonates, we've got the rank ligand inhibitor, there's just one we're going to talk about, and the selective estrogen receptor modulator, again, there's just going to be one. We also have anabolic agents, which are going to help you build up bone, and that includes your parathyroid hormone analogs. We're going to discuss two of them. And a newer medication, it is a sclerostin inhibitor. We're going to discuss that medication. And then I'll give you some general information about the last line therapies, calcitonin and the conjugated estrogens with beta-doxyphene, but these are not recommended. So I'm not going to spend a lot of time going into it because we're really probably not going to be using these agents very often. The next thing that I want to discuss is basic information about calcium supplements. And I want you to note that if there's any way that you can get dietary calcium and vitamin D, that would always be a preferential form of these supplements before actually taking them in a tablet or some type of supplemental form. You should always try to use dietary intake first. And with calcium, we use that because it helps increase bone mineral density in patients who may have an issue with osteoporosis. And it's important that your patients know that there are two different types of calcium. You can get calcium carbonate and calcium citrate. If you get calcium carbonate, you're going to be looking at 40% elemental calcium, whereas calcium citrate is only 21% elemental calcium. And that's important because if you are trying to help your patient take fewer calcium supplements, they may have more luck with using calcium carbonate because there is more calcium in it and it's cheaper, but there are instances where calcium citrate would be preferred. I want you to note that Some calcium supplements may have more than 600 milligrams per serving, but in general, it is not recommended to exceed 600 milligrams of elemental calcium per dose. And that's because calcium absorption becomes saturated at that point. And then, even though you're taking more than 600 milligrams, it's really not doing any good. It's just adding to your daily intake. So, it's preferred that if you see a product that has over 600 milligrams per serving, don't recommend that product. Go ahead and make sure that they're not getting more than 600 milligrams per dose. Also, it's okay if you have a daily dose higher than 600 as long as it's divided. Remember, you can divide it into 2 or 3 doses depending on how the supplement tells you to divide it. An acidic environment is required for the absorption of calcium carbonate, which is why it's recommended that you take it with food. And you need to keep that in mind if you're taking another medication as well, because calcium carbonate can interfere with other medications, or if you take it with something that can't be taken with a full stomach, then you might also have an issue with absorption. So make sure that they know exactly when to take that calcium carbonate, because it does have to be with food so that there's an increase in gastric acid. If you have a patient who's maybe using an acid suppressive therapy like a PPI, or if they are unable to take it with meals, it's okay for them to use calcium citrate. That actually does not require gastric acid, so it may be a preferred option for those patients. When you're looking at calcium supplements, you'll notice that calcium is pretty well tolerated, but there are some disease-related concerns. If you increase your calcium intake, then you're going to increase your calcium levels, and that might go overboard, and then you might have too much calcium in your body. So it's important that you tell your patient how much they should be taking in, and we'll get into that. Also, they might experience kidney stones, and kidney stones have specifically been identified as more commonly being a calcium oxalate stone, and that's more likely to occur with calcium carbonate supplementation than with calcium citrate supplementation. So if a patient has kidney stones and they need calcium, you should recommend that they try calcium citrate if they can. If a patient has renal insufficiency, then they're going to have trouble getting rid of some of that calcium, so you have to make sure that they're monitoring their intake and also that their levels are being checked, because again, we might go overboard and have too much calcium in these patients. The adverse effects really aren't too serious as long as it's not huge hypercalcemia problems, but they do tend to get constipation, so you should always recommend that your patient drink lots of water and fluid intake, and then also that they have a good diet that's high in fiber. If you have a patient who's taking other medications, calcium can interact. Specifically, bisphosphonates are something to consider, because bisphosphonates are another type of treatment, as we're going to see in a second, that you can use for osteoporosis. But bisphosphonates cannot be taken at the same time as calcium, but they require that you take calcium. So you're going to have to make sure that you're very deliberate in telling them to space out the calcium intake from the bisphosphonate if they're taking a PO form. Other interactions to consider are listed. I want to mention thiazide diuretics, because as we know, those can increase calcium levels, and if you're taking additional calcium supplementation, then there's a chance that you're going to have too much calcium in your body. Also, levothyroxine absorption is decreased when it's taken with calcium, so if you have a patient who requires Synthroid, they should be spacing out calcium supplementation by about 4 hours. When we're telling a patient to monitor for any side effects that may occur with calcium, primarily we're going to be wanting them to watch out for changes in their serum levels. We want to make sure, first of all, that they're not taking too much calcium. Again, I'm going to go over that dosing next. But also, we want to make sure that their lab values are normal in terms of calcium. Remember that calcium and phosphate tend to have a different reaction in the body, and when one goes up, the other one tends to be lower. So if you increase your calcium, you may decrease your phosphate levels, or vice versa, which is why it's important to keep an eye on both of those lab values. For patients who can't swallow tablets, they do have other formulations. You can get gummies and chewables. There are a lot of different calcium formulations available, tons. But again, keep an eye on that dosing, because we don't want to recommend something that has more than 600 milligrams of elemental calcium per dose. Also, as I said earlier, if you do have a patient who has kidney stones, it is recommended to use calcium citrate instead of calcium carbonate. Here I have the dosing information that I told you that we'd talk about. Again, remember there are tons of different types of calcium. These are just a few examples. And for the dosing, I'm really just going to focus on make sure that you know that daily range, anywhere from 1,000 to 1,200 milligrams of elemental calcium per day. Remember, again, that depends on your sex and your age. But also remember that if we're going to go with a dosing regimen, we need to make sure we're not using more than 600 milligrams of calcium per dose. And we want to make sure that we do not exceed 1,500 milligrams. It is not recommended to go over 1,500 milligrams. The guidelines, AACE, recommend that you should just cap out around 1,500. There's really not much benefit going above that anyway, so just focus on this general dosing information because there are so many different supplements, it's impossible to learn the ins and outs of every single brand. Just know what you should be aiming for. The next lecture embedded question that I have is also one that you need to do as a team. I want you to tell me how much elemental calcium does Mrs. Penny need, and then what would you recommend as a product for her? And I want you to include your rationale, the dosing, and the frequency. And again, be sure to write all this down on the paper that you're going to turn in. Here I have the information about vitamin D. Remember that we would recommend that patients, of course, get vitamin D through a dietary source first if possible, but if not, there is supplementation, obviously. It is recommended that you use vitamin D because it can increase vitamin D levels in general, but also vitamin D can help with calcium absorption, so it helps in almost two different ways in patients who have osteoporosis. And you'll notice that vitamin D is available in two different forms. There's D3, which is your cholecalciferol, and your D2, which is your ergocalciferol. And again, you should really make sure that you use supplementation if you notice that there's a deficiency in a patient's vitamin D levels. There are some contraindications. The important one I want to mention is malabsorption of any kind, because if you have a patient who has either irregular absorption due to some type of an intestinal problem, or if they're not absorbing any vitamin D, of course that's not going to even treat the osteoporosis if you're not getting any vitamin D, but also if the patient is absorbing it and it depends on the day or it depends on how they're feeling and it's variable, then that means there might be days when they need more vitamin D. Or maybe there's a day when they're absorbing more than is expected, and then you run the risk of maybe having them take too much vitamin D. And that can lead to something else, another contraindication, called hypervitaminosis D. And that just means you have elevated vitamin D levels. And so you need to watch out for patients who aren't going to have consistent absorption because we could either be too low on vitamin D or too high. The primary warning and precaution would have to do with toxicity, and really, toxicity is based on primarily GI symptoms that you're going to notice in a patient. They're going to have like nausea, vomiting, decreased appetite, constipation, dehydration, confusion, maybe even fatigue. So they need to be aware of what to look out for if they do have vitamin D levels that are too high. As well, we want to keep an eye on other things like renal impairment. Vitamin D should not be used with any other vitamin supplementation without talking to the doctor first. And that's because you might be getting too much vitamin D. And remember, as I stated earlier, when you're looking at adverse effects of vitamin D, we've primarily really only got toxicity, so it's pretty well tolerated as long as you don't have a patient who's absorbing too much vitamin D. And that would make sense then that our monitoring parameters should include vitamin D levels and calcium levels. One thing I do want to point out is that there is a drug interaction with vitamin D and thiazide diuretics. Remember how thiazide diuretics can increase calcium levels. And remember how vitamin D can also help increase calcium absorption. If you have a patient then who's using a thiazide diuretic with an increased level of calcium, and they're also taking potentially a calcium supplement with vitamin D, we could have even more calcium levels going up in that patient than if they were just taking calcium with a thiazide. So the vitamin D issue with the thiazide is primarily that we could have even more increased calcium because vitamin D will help absorb more calcium, if that makes sense. So you should always make sure that both the vitamin D and the calcium levels are within the proper recommended range. So here I've got vitamin D dosing information, and we should again always try to reinforce to the patient that nutritional intake of vitamin D is much more preferred to a supplemental form of vitamin D. However, if they do need a supplemental form, especially if they have osteoporosis, I do have a relative target dose listed. Again, this target dose is from the AACE guidelines, and your DiPiro book will also back up this dose as well. You know, there are different ranges that DiPiro also mentions, and your Hutchison book also gives different recommendations depending on the patient, but for purposes of keeping the most current information, the AACE guidelines are from 2020, and they recommend that anybody who has osteoporosis take in 1,000 to 2,000 units per day. They do mention that there is an instance where you might have to adjust that, and that's basically going to be a patient-specific factor. Maybe the patient is obese and needs a little bit more. You do need to watch out because there is a general max dose of 4,000 units per day, but the guidelines do mention that there are cases where you might need to give slightly more than 4,000. It's not an absolute max dose, but we do tend to prefer keeping doses under 4,000 units because that's known to be the upper safety limit without having very many, if any, side effects. Notice that I did not include the 50,000 units per week dose, and that's because, yes, I know you've seen it in the pharmacy. People sometimes come in with a 50,000 units per week dosing regimen, but that is not a target regimen. That's used if the patient does have a pretty substantial deficiency. The guidelines actually mention that usually the need for that much is not there. It's very uncommon actually to need 50,000 units per week, but it could happen. And if it does happen, you should only have them taking that until they reach proper serum levels, and then you go to this target dose again of 1,000 to 2,000 units. So for ease for you guys, I'm going to just have you look at that target dose. Once we've gotten levels normalized, we should be maintaining 1,000 to 2,000 units per day. Also, as I said earlier, keep in mind if there are other factors like weight that could affect that max dose. When you're counseling patients on supplements, I think the most important thing to remember is their daily intake. And remember that when we are talking to patients who are going to use calcium, that's going to be affected by their sex and their age. So make sure that they know, first of all, not to exceed 1,500 milligrams a day. Remember, that's our recommended max dose. And reinforce that rule about not taking more than 600 milligrams per dose so that absorption is optimized. Make sure that they know the age ranges and the sex-related dosing regimens so that everybody is getting the proper amount. Remember to tell them that with calcium carbonate, again, we need an acidic environment in the stomach, so they should be taking that with food. But if you have a patient who can't take their medication with food, or if they're on an acid suppressing therapy, it would be preferred to take calcium citrate. The dietary sources of calcium should definitely be mentioned to your patients because remember, we should always go for improving dietary intake before we go to a supplement if that's possible. So you should always recommend things like dairy products, and I've listed some of them here, but I'm also aware, and you know too, that some people can't have lactose, but there are lactose-free products that still have calcium, like Lactaid. I even have actually tried this. The calcium-fortified orange juice is actually very good. So that's another option. If people like orange juice and if they don't have to worry about sugar or something, they can try that, and it has some calcium in it. Make sure they know about constipation so that they know the importance of having adequate fluid intake and then eating a rich diet in fiber. When you're counseling on vitamin D, recommend to them again to be taking in about 1,000 to 2,000 units per day. And again, that max dose of 4,000 units, make sure if they are one of those exceptions where they may require more, then have them go with what the doctor says. But in general, if it's just a patient who's going to be taking vitamin D, recommend 4,000 units is the maximum. Also, this is very important because you're probably going to have a patient say, oh, I go outside a lot, so I'm getting a lot of vitamin D. do not recommend sunlight as the vitamin D source because, first of all, dietary is always preferred, but also if you go outside, the patient actually can't have their arms covered. They need to have their arms completely uncovered to absorb that sunlight. And then that means we have an issue where we might be increasing our UV exposure. So the patients should not be using sunlight as their means of dealing with a vitamin D deficiency that could cause cancer. So always make sure that they know if they can't get dietary vitamin D, they should go to a supplemental source. Sunlight in general isn't necessarily too bad, but you shouldn't recommend it as the way to get vitamin D. And there are some foods that they can try. There are, for vitamin D3 sources, it tends to be an animal-based source, so you may have fish, eggs, fortified dairy. There is also an option if you have a patient who maybe doesn't want to take an animal source. They could try mushrooms because mushrooms and other fungal sources, as long as they've been exposed to UV light, they do have some vitamin D too. Also, make sure that the patient knows that if they are taking a weekly dose, that they should not be taking that on a daily basis. I know that seems kind of common sense, but you should reinforce it. There were actually some studies that I read about people saying that their patients ended up taking the weekly dose on a daily basis. So make sure if they are on that 50,000 unit dose per week for some reason, they should not be taking that more than once a week. Also, make sure you reinforce the signs of vitamin D toxicity, like our GI symptoms, the constipation, confusion, fatigue, anything like that. Make sure they know about it. Now we're going to discuss the first major class of osteoporosis medications. I talked about it a little bit with calcium, but here we go. These are the bisphosphonates. And I have some blanks here for you to go ahead and put in the brand names, so fill those into your packet. And I want to talk to you a little bit about these formulations. First, in general, know that bisphosphonates are a first-line therapy for treating osteoporosis. And that's really helpful because there are tons of different types of bisphosphonates. Notice how Benosto is an effervescent tablet. And that's really good for patients who can't swallow well because it can basically dissolve, so you don't have to worry about them swallowing like a giant horse pill. Also, notice I have Atelvia on here, and Atelvia is a delayed release tablet. And I'm going to get into this a little bit later, but that's important because it affects when you take that medication. Also, I have included Reclast, and Reclast is used for patients who have an issue with osteoporosis, and it comes in an IV. Notice that there is another brand name for zoledronic acid for treating hypercalcemia of malignancy, but we're not going to get into that. That's outside of the scope of this lecture. So I want you to focus on Reclast because that's what we actually give for osteoporosis patients. Here is the information for bisphosphonates. The general mechanism is that we're going to inhibit osteoclast function. What does that mean? That means that we are no longer going to be breaking down bone, which means we have an opportunity to increase our bone density. That's why it's called anti-resorptive, because we're not resorbing bone. Notice that there are some very specific rules for administration, and they must be followed to the T based on what I've listed here. You should not take a bisphosphonate with anything besides water, because that can affect its absorption, that can affect whether or not it irritates you in general. Just know, don't take it with anything except water. Also, there is a requirement that you stay upright for 30 minutes for most of the bisphosphonates, but it's 60 minutes with Boniva. And that's because, if you think about it, if you're lying down, that bisphosphonate some of that residue might start irritating your esophagus. And there is a chance that esophageal abnormalities can occur with a bisphosphonate. So in general, you should not be lying down. You need to follow these rules about staying upright. You'll notice also that we have some meal separations that are recommended. 30 minutes from a meal for most bisphosphonates, or if we've got Boniva, it should be 60 minutes away from a meal. There is only one bisphosphonate that's oral that should be taken after eating, and that's Atelvia, because Atelvia is a delayed release formulation and it requires an acidic environment. That is the only one that you should take with food, and technically it should be taken after eating breakfast. So contraindications. If the patient cannot follow the administration rules, they should not be taking a PO form because there could be really serious problems that happen. One of them kind of like what I was talking about when you need to be upright. Remember that bisphosphonates in general can cause some type of esophageal irritation. If you have a patient who has an abnormal esophagus and then they're also taking a medication that can irritate the esophagus or they're not staying upright, that means that the patient could potentially exacerbate a pre-existing problem. Maybe they'll develop esophageal strictures and those can lead to cancer. So that kind of goes along with the other contraindication. If they can't swallow the bisphosphonate PO, they should not be taking it because, again, we don't want to increase that irritation on the esophagus, and it can also do other things like heartburn. Any patient who's got hypocalcemia should not be using a bisphosphonate because bisphosphonates will actually decrease calcium levels. And remember I said you should be taking calcium, but you need to be spacing it out because you could have too low calcium levels if you're not taking calcium with a bisphosphonate, but if you take it together, you're not going to be absorbing something correctly. Warnings and precautions you need to describe to the patient. Some of these are kind of rare, but they're very serious. One of them is osteoporosis of the jaw. That's basically when the jawbone starts to break down. And that can tend to happen if a patient maybe has poor dental hygiene or if they've recently had a procedure. So it's always recommended that before starting this therapy, that you have them go ahead and get checked out by a dentist and make sure that there's not some underlying issue that's going to cause the jawbone to get damaged. Also, I've mentioned atypical femur fractures, and they're basically called that because you know your femur, that's your thigh bone, right? Your femur is huge. If your femur is just randomly fracturing, that is not normal. It is definitely abiding by that term, atypical. So they may have a thigh bone fracture. Also, like I mentioned, esophageal damage can occur. And I want you to focus on these renal impairment rules because there are certain creatinine clearance thresholds where we should not be taking these. If a patient has a creatinine clearance less than 35 milliliters per minute, they should not be using alendronate and reclassed. If they have a creatinine clearance less than 30, that basically precludes all the other bisphosphonates. So make sure that you're keeping an eye on which creatinine clearance you are looking at when you recommend a therapy to a patient. Primarily, side effects of bisphosphonates will be hypocalcemia. So the patient needs to know what to look out for hypocalcemia. And a little bit later, I'm going to go over how to counsel on that, but that is a very serious side effect that can develop. Also, with the PO forms, like I said, there can be some heartburn, some GI issues, esophageal issues. The injectables don't really cause that as much, but they have their own problems. They can cause some flu-like symptoms, but those can be mitigated with giving acetaminophen. Notice that there are some drug interactions. Anything that is a cation-containing supplement or an antacid, we're going to have a reaction because remember that affects absorption. Also, if we are having a patient who's taking a Telvia, we have to have an acidic environment. So they should not be taken with any acid suppressive therapy because then the Telvia is not going to dissolve, right? It's not going to be absorbed correctly. Also, we have NSAIDs on here because NSAIDs can already cause some GI irritation, and if you are taking a bisphosphonate as well, we're just going to magnify that problem. Monitoring, tell the patient to look out for signs of osteonecrosis of the jaw, like if they have jaw pain. If they have any type of thigh bone pain, that could indicate that they have that atypical femur fracture, and they should be getting their serum calcium levels monitored regularly to make sure there's not too little calcium in the body. Here are some recommendations for when to recommend a bisphosphonate. First of all, since it's first-line therapy, always keep these at the forefront of your mind unless there's a reason that they can't be given for some reason. Also, notice that if you're going to have a patient taking a Telvia, they need to know, again, it needs to be taken after they eat breakfast so that there is an acidic environment. Also, something to consider. Yes, it's great that we have an effervescent tablet form, the Benosto, but patients sometimes can't tolerate that because it does have a sodium component. So if you have a patient who maybe has heart failure or hypertension, then they might be sensitive to that sodium. So you shouldn't be using it in patients who could exacerbate some type of a cardiovascular issue with the increased sodium levels in the effervescent tablet. If you have a patient who has an esophageal issue, that doesn't mean that you can't use a bisphosphonate. It just means you can't use a PO bisphosphonate. The injectables don't affect that. So that is an option if you have someone you want to give them first-line therapy, but they have an esophageal problem, recommend an injectable. Remember, first-line therapy, and this is also something to consider, something called a bisphosphonate holiday. And a bisphosphonate holiday can be considered in patients who begin to have a decreased efficacy with bisphosphonate therapy. But that holiday, there's really no recommended time length other than it should only be temporary enough so that when the patient restarts therapy, the medication is working effectively. In general, it's recommended that you take a holiday after 5 years of a PO bisphosphonate or after 3 years of an IV bisphosphonate. And if you do have a patient who is at very high risk for fractures, but they haven't had a fracture in a while, then they can consider a PO holiday after 6 to 10 years of bisphosphonate therapy. So I've included the dosing information for bisphosphonates, and I know there is a lot here. First of all, the only doses I included are actual doses when a patient has confirmed osteoporosis. There are some preventative doses. I'm not going to include all that. I want you to focus on the frequency of when you should be taking these because there are so many different dosing regimens. Notice that your alendronate can be given weekly or daily. And look at risedronate. Do you notice how men, they really only take it weekly, but females have daily, weekly, or monthly options. Men cannot take a monthly dose of risedronate. That's female specific. Also, look at our ibandronate. You'll notice that that can be given either monthly if it's oral or every 3 months if it's IV. And our zoledronic acid, that's unique because it's an annual dose. So that's pretty convenient for patients who can't take a PO medication every day. So when you're counseling a patient on how to take bisphosphonates, make sure they very much understand the different rules for how to take a PO form. They should be taken on an empty stomach, the exception, of course, being a Telvia that requires the acidic gut, so it must be taken after breakfast. But with most of your bisphosphonates, it's going to be that they need to be taken at least 30 minutes before food enters the stomach. That way it's got time to be absorbed properly. And if the patient's taking Boniva, they need to wait 60 minutes to eat as a minimum. Also, if a patient's taking a PO bisphosphonate, they need to be using 8 ounces of water because that'll help with maybe some of the discomfort that the medication might cause in terms of heartburn. Also, the patient should be staying upright. Remember, we want to minimize the patient's esophageal irritation that they might get. So they should be staying upright for at least 30 minutes after taking it. But if it's Boniva, that's going to be 60 minutes. With Benosto, there are some very specific administration instructions. It is dissolved in 4 ounces of water, and that does differ from the fact that the PO, other bisphosphonates, are taken with 8 ounces. Benosto uses 4 ounces of water. Also, patients, after they dissolve it in water, they're supposed to let it go until effervescence stops, and once that stops, they're supposed to wait another 5 minutes and then stir it. So it may seem tempting for them to stir immediately, but that's not how it's supposed to be administered. Make sure that they know about the potential for heartburn because they need to be looking out for other irritation signs, maybe esophageal pain. They need to know to talk to the doctor if they are having esophageal issues. And then when you're counseling on the injectables, remind them that if they do have that acute phase reaction that causes those flu-like symptoms, they can take Tylenol, and that can help get rid of some of that discomfort. For all of the bisphosphonates, remind the patient about the potential for a severe jaw infection, osteonecrosis. Make sure that you don't call it osteonecrosis because that's not a very simple term for patients to understand. Make sure that they are looking out for signs of thigh bone pain because that could indicate a femur fracture. And remind them again of signs of low calcium like cramps, muscle spasms, or numbness. The next lecture question that I have for you guys to answer as a team is based on Ms. Penny's creatinine clearance. Which medication or medications is or are not recommended? So make sure you provide a rationale with your answer. Your 7th question, I want you to list the advantages and disadvantages of Mrs. Penny using an oral bisphosphonate for her osteoporosis. Make sure that you're providing rationale as well. Again, advantages and disadvantages of using an oral bisphosphonate in Miss Penny. The rank ligand inhibitor that we're going to talk about is denosumab, and we're going to be focusing on the brand Prolia. That's the one that's used in osteoporosis. And Prolia is a monoclonal antibody, and the mechanism is that when that monoclonal antibody binds to rank ligand, then rank ligand can't bind to rank, and rank is a receptor that you can find on an osteoclast. So if there's no binding to the receptor, then there's a reduction in osteoclast formation, and that leads to a decrease in bone resorption and an increase in bone mass. Denosumab must be given by a healthcare professional. There is a chance that people might have some type of a hypersensitivity, so it should always be given by a professional. It's not something that the patient would give himself or herself. It is contraindicated in pregnancy, and that is something that you're probably not going to see very often. There aren't very many patients with osteoporosis who are also pregnant, but just in case, you should know you should not use it in pregnant patients. And also, if a patient has low calcium levels, again, they should not be using this medication if the calcium is too low, because it's already going to lead to low calcium. We could have a serious problem in terms of serum calcium levels. You'll notice the warnings are very similar to the bisphosphonates. We have the osteonecrosis of the jaw and the femur fractures, but also we can have skin infections or skin reactions. Remember, if it is something that can cause hypersensitivity, then that might lead to something like dermatitis, something in the skin, and infections. It could lead to a skin infection as well as the infection like osteonecrosis of the jaw. Prolia can also cause infections and pain in the joints, back, and limbs. And since it is a monoclonal antibody, there may be some immunosuppressant activity. So if you combine it with another immunosuppressant, that may magnify the activity on the body. So patients need to be careful if they're taking other immunosuppressants at the same time. For adverse reactions, again, we've got relatively normal ones. Things that are different to keep a lookout for, though, would be like the infections and the pain, and monitoring. Monitoring, of course, is going to be similar to what we saw with the bisphosphonates, but also bone mineral density is one. And that's because if the medication isn't working, it's not recommended that we keep having the patient take it. So if there's no improvement, they shouldn't really be using it. But also, patients who come off of Prolia can have very rapid decreases in bone mineral density. It can actually happen very, very quickly. And so if a patient stops taking the Prolia, bone mineral density can decrease so quickly that they may start to have fractures potentially. So it's always recommended that if a patient has to come off of it, that they start some other anti-resorptive therapy like a bisphosphonate to prevent that rapid loss of bone mineral density. Also, it is not necessarily considered to be a first-line therapy, but if a patient has a very high fracture risk, that's when we would go to this medication. So it can reduce the risk of vertebral, non-vertebral, and hip fractures. So that's when we would prefer maybe using Prolia potentially over a bisphosphonate if it's a very high fracture risk. Here, I've included the dosing information for Prolia. Remember, again, it's a subcutaneous injection, but it must be given by a healthcare professional. And notice how it's given every 6 months, and that's an advantage because other injectables have to be daily, but this one does not. When counseling a patient about Prolia, I have included, of course, what we just talked about, that it's a 6-month injection given by a healthcare professional. And I've also included the fact that it can lower your calcium levels, and remember, I've given signs of low calcium here. And we have those infections that may occur, same as with bisphosphonates, but with the added infection of potentially a skin infection. Again, we have that thigh bone fracture that might occur, so make sure the patient knows that they might get a thigh bone fracture. They should be looking out for thigh pain. And I've included some skin reactions, the hypersensitivity things like rash, dermatitis, eczema. And I've also included, this is very important, that you have the patient talk to the doctor before stopping, because remember that bone mineral density very quickly can revert back to the way that it was before you started Prolia. So they need to know that they should not just stop this medication unless the doctor has a plan for some other type of osteoporosis treatment. Now let's move on to the selective estrogen receptor modulators. Remember, the one that's used in osteoporosis is raloxifene. There's only one that we're really going to use. And raloxifene is interesting because its mechanism involves both agonism and antagonism of estrogen in patients. It's used in women, and notice that when it acts as an agonist of estrogen, that's occurring at the bone tissue, and that will result in a decrease in bone loss. It also acts as an antagonist in breast and uterine tissue, which can potentially reduce cancer rates. So the mechanism of raloxifene is that it will prevent bone loss by decreasing bone resorption, and then that causes an increase in bone mineral density and a decreased incidence of fractures. You'll notice the black box warning kind of makes sense if you consider the fact that estrogen is involved. We might have patients get a venous thromboembolism or a stroke, so caution should be used in patients who have some underlying cardiovascular issues. It should not be taken if a patient has a history of VTE or if they're pregnant. Some warnings to look out for, of course, would be signs of a stroke or a clot. I'm going to go over that when I discuss counseling. And also triglycerides, because raloxifene can actually increase triglycerides in patients. For adverse effects, probably the most commonly complained about one is a hot flash, and that can be frustrating if the patient is dealing with maybe some hot flashes due to menopause or whatever. That's frustrating, but if you're taking it, as we're going to discuss a little bit later, it's usually to prevent some cancer risk, predisposal to breast cancer. So that means that the patient may have to find a way to adapt to the hot flashes because it has some benefits of using this medication, and hot flashes shouldn't be a reason that a patient stops it if it's being used for preventing some type of cancer. Also, drug interactions are important because you'll notice with Synthroid, it interferes with absorption, of course, but also it can interfere with the absorption of a bile acid sequestrant. So we would have to make sure that the patient is spacing out the raloxifene in those medications. And like I said, they should be monitored for triglyceride changes because it can increase triglycerides, and also bone mineral density. And I put that there because if the medication isn't working, it has enough serious side effects that it's not worth continuing to take it if we're not going to see any type of added benefit from it. Also, I've included blood clots because that's a very big risk with estrogen medications. In patients who do have a risk of breast cancer, it is recommended to use raloxifene. And if there is a patient who has low bone mineral density in the spine, they can actually use it with another osteoporosis medication for added benefit, because raloxifene does not prevent low bone mineral density in the hip, but if they have it in the spine and if they want to use it for cancer prevention, the AACE guidelines state that patients who have a high risk for fracture can combine it with maybe a bisphosphonate or Prolia in order to continue getting the added benefit of breast cancer reduction in high-risk fracture patients. Dosing for raloxifene is done on a daily basis, and you'll notice that it's an oral medication. So even though it is a daily dose, at least it's not something like an injection on a daily basis, but it will be daily dosing. And also notice that it's for postmenopausal women, not men. So men are not going to be taking this medication. When counseling a patient about raloxifene, the most important things to focus on would be signs of a clot or signs of a stroke. So I've listed signs of a clot here, things like leg pain, chest pain, that may indicate, that there's a VTE or an actual pulmonary embolism. Things like redness, swelling, difficulty breathing, any of that could indicate a clot. And then signs of a stroke. Obviously, headache is one, but also you need to keep in mind that FAST acronym, facial drooping, maybe weakness in the arms or legs, slurred speech. And if they notice any of those things, they should rapidly report to the doctor, because remember that the longer you go with a stroke, the more potential damage can occur in the brain. Also, hot flashes can occur. Make sure they know that the medication, they're taking it for a very good reason, so they need to try to find another way to handle the hot flashes rather than stopping the medication. And if a patient is going to be immobilized, they should stop taking this medication 3 days prior, because the added risk of clot from the medication is going to be compounded with the risk of clot from not moving around. So if they know they're going to have surgery and be immobile, they need to be stopping this medication 3 days before that procedure or period of immobilization. We have two parathyroid hormone analogs that we're going to discuss. And the mechanism of these, it's pretty self-explanatory. These actually behave like parathyroid hormone does in the body. And they're considered anabolic agents because since they are acting like parathyroid hormone, they are going to be stimulating osteoblast activity. And this will lead to an increase in bone formation. Keep in mind, though, that as you increase parathyroid hormone activity, that also can increase calcium levels in the body. This medication may cause bone cancer. That's what osteosarcoma is. And so in order to decrease this risk, there is actually a recommendation that this medication not be used beyond 2 years. Another thing is to tell the patient about some warnings to look out for. Of course, bone cancer is one. If they're feeling bone pain, that's something to report to the doctor. But also, right here I've mentioned orthostatic hypotension. And remember, our geriatric patients, they're probably on other meds that could also cause the same thing. And if we have a medication that's going to be causing them to be dizzy, then there's an even higher risk of potential falls and fractures. So patients should be told if they're going to take a medication like this that can cause dizziness, they need to sit down when they feel it. Also, there is an increased risk of urolithiasis. That's just a fancy term for urinary stones. And I want you to notice that the symptoms, side effects to look out for, dizziness is on there, but TIM-LOS, that's one particular parathyroid hormone analog that we have, it can increase levels of uric acid. So patients who have gout may have hyperuricemia. That's something that they should be checked for because that can make the gout worse. Also, monitoring, of course, like we've kind of said earlier, if there's not much of an improvement in bone mineral density, it's really not worth continuing a medication that could lead to serious things like osteosarcoma. Clinical pearls, I want you to remember that 2-year maximum. That's the longest that it's recommended to use these because we simply don't have enough data to know what will happen after 2 years, and that risk of cancer makes it not a very good option to use beyond 2 years. But these are good options if a patient has a very high fracture risk. They are not necessarily last line, but they really shouldn't be used unless they're really important and the benefit outweighs the risk. So I've included the dosing here. And remember when I was talking about Prolia, how I said that it's advantageous that it's only every 6 months? These injections are also subcutaneous like Prolia, but notice that they are daily dosing. That is not the most fun to give yourself a shot every day. And also something to consider to tell the patient with the dosing is that while it is a subcutaneous injection that comes in a pen, the pen doesn't have needles in it. So patients are going to have to get their needles separately. But definitely focus on this daily dosing because that may make it a little more frustrating for patients simply because of the frequency of injecting themselves. When counseling a patient about the parathyroid hormone analogs, I think the most important thing to focus on first would be cancer. You need to tell them if they're having bone pain, they need to go to the doctor because that could indicate that osteosarcoma that's, the black box warning. Also, it may cause dizziness, so they need to know, like I said earlier, if they're feeling dizzy, they should sit immediately. They should not be up and about after they've taken it unless they know that they can tolerate it because we don't want them to get another fracture. Also, if they're going to be injecting it, they need to know where to inject it. They can both be injected in the abdomen, both forms of the parathyroid hormone analogs. However, the Forteo injection can also be injected in the thigh. So that gives a little more variety And remember, tell your patient to rotate injection sites. That helps with maybe some irritation. These do have to be refrigerated, but if we are going to refrigerate them, we need to let them know what the discard dates are. It's pretty much a month, but Forteo is technically 28 days versus 30 days for Timloss. And make sure they know after 2 years these should not be used. So they need to be following up with the doctor once they're getting close to that 2-year point to see what the next plan is. The sclerostin inhibitor that I want to discuss is romosozumab. And the general mechanism I want you to know is that romosozumab inhibits sclerostin, and that leads to increased bone formation. Specifically, what's happening is consider that sclerostin is actually a bone factor that normally inhibits something called the Wnt beta-catenin pathway. And when sclerostin inhibits that pathway, then differentiation into osteoblasts is inhibited. So when romosozumab is able to inhibit sclerostin, then there's no longer inhibition of the Wnt pathway, and that means that bone growth can occur. There is a black box warning for romosozumab. It's going to include things like cardiovascular problems, heart attack, stroke. And I want you to look at the contraindications. Uncorrected hypocalcemia is one, because if a patient's calcium levels are too low, this medication could make that worse. You want to discuss with the patient the regular warnings and precautions. We've seen a lot of these, but the newer one to consider again is cardiovascular events. Make sure they know what to look out for if they need to go to the doctor. Another thing is that if a patient is going to be on this medication, they need to be monitored for their cardiovascular health. They should be checked regularly to make sure there's not an underlying problem developing. If it's not working, if the bone mineral density is not where it should be, it's worth considering finding another medication, because we don't want to use a medication that's high risk if it's not providing any benefit. Also, calcium levels should always be monitored because we don't want to decrease calcium too much. This medication can only be used in women. It's not used in men. And also, really, the parathyroid hormone analogs would be used before this. This is considered a not first-line medication. It is a rescue therapy if a patient has a very high fracture risk, and if the parathyroid hormone analogs, for some reason, are not effective in helping the patient's osteoporosis. The dosing information that I want you to pay attention for romosozumab is that it is a monthly injection. And also, the injection is not given all at once. It's divided into 2 consecutive 105 milligram subcutaneous injections, but the overall dose, the 210 milligram total, is given every month. When you're counseling a patient on romosozumab, the most important things will involve signs of heart attack, stroke, and I've listed them here, and I've discussed those earlier. But again, heart attack, chest pain, difficulty breathing, dizziness. Make sure if you have a patient like a female, remember they may have atypical signs, so things like nausea, maybe shoulder pain, things that aren't necessarily common signs of a heart attack still need to be mentioned to the patient in case they're having atypical symptoms. Also, this medication is not supposed to be used beyond a year, so we're looking at 12 total doses, so the 210 milligrams for 12 doses. Also, even though this medication is refrigerated, the patient needs to let it sit for 30 minutes before they inject it so that it comes to room temperature. You'll see common things like jaw infection and thigh bone fracture that you need to mention to the patient, as well as low calcium signs like cramps, muscle spasms, numbness. These things all need to be discussed with the patient. Last line therapies, according to the 2020 AACE guidelines, are listed on this slide. I've mentioned calcitonin. Calcitonin inhibits osteoclast activity, which in turn will inhibit bone resorption, but it is last line. Here are some of the reasons. The AACE guidelines mention that hypersensitivity is an issue. Remember that calcitonin has some type of salmon byproduct in it, so patients who have a salmon allergy may have a hypersensitivity reaction. Also, the guidelines mention that it is just not very effective in helping with osteoporosis, including this increased risk you can see of cancer. So when you consider allergy, cancer, lack of efficacy, you can see why it's last line. It does come in a nasal spray, which may be helpful for some patients, but it's still not going to be used very often. Another thing that the guidelines mention as a last line treatment would be conjugated estrogens combined with basidoxifene, and that's a medication known as Duavi. And Duavi can be used in women with a uterus, but there's an increased risk of endometrial and breast cancer because of unopposed estrogen use. You need to consider that, remember, raloxifene does have a VTE stroke risk, but it has that added benefit of lowering the risk of breast cancer. The guidelines mention that Duavi, its effect on breast cancer really isn't known, and there is that increased risk of having breast cancer from using unopposed estrogen. So in general, it's really not recommended that you use Duavi unless you're under the supervision of a gynecologist who's giving it for a very specific purpose in osteoporosis. It may help with some vasomotor symptoms of patients going through menopause, but remember that has drawbacks due to VTE risk, breast cancer, things like that. Also, this medication has not been studied in patients over the age of 75. It is not appropriate to use then in patients older than 75 years of age. And the lack of evidence is why it's considered a last line therapy. When you counsel a patient about calcitonin or Duavi, there are a few things you should mention. Calcitonin, if they're going to use the nasal spray, they need to prime it. So you need to explain that means they're going to be pumping the nasal spray 5 times before they get the first dose. Make sure they know about that increased risk of cancer so that they're keeping an eye out for anything that might be abnormal going on in their bodies. And make sure you know if they have a salmon allergy because they may have some type of an allergic reaction. Make sure they know what maybe would be indicative of a reaction, like facial swelling, trouble breathing, signs of anaphylaxis like low blood pressure. Also, the calcitonin should only be used for a month and then it needs to be discarded. And notice that it is stored in the refrigerator. Also, notice that it can increase calcium, and that's a little bit different. So I've given signs of increased calcium, weakness, constipation, stomach pain, confusion. These are things you should mention that the patient should look out for. Another thing I want to discuss is the Duavi counseling. Make sure that the patient knows there is a potential risk for breast, endometrial, or ovarian cancer, so they should be going to the gynecologist regularly and under the supervision of a gynecologist. Make sure again that they know signs of clot and stroke. I've listed them here for you. You've seen it this whole time, but here they are again. So make sure the patient knows exactly what could indicate a clot or a stroke. Your last lecture question, number 8, I've listed here. I want you to explain, is Mrs. Penny a good candidate for Duavi therapy and why or why not? So include your rationale. Make sure you write this down and answer it. The role of the pharmacist, I've listed them here. One of the things that's very important is to identify medications that can exacerbate osteoporosis, maybe lead to osteoporosis, or increase the risk of fractures. Whenever you notice those, make sure the patient is aware of what kind of fall risk there is or whether there's a potential for loss of bone density. Make sure that the patient knows how much calcium and vitamin D should be recommended based on the age and medical history and sex of the patient. Be sure that patients know how to take their medications appropriately so that they're not potentially having a drug interaction or having a lack of absorption. Make sure that you notify the doctor if you notice that there is a drug interaction that's problematic, and patients need to know whether or not they need to space out their medications and if there are certain OTC meds or supplements that should be avoided. Again, you should emphasize lifestyle modifications because lifestyle modifications are actually sustainable and don't have the same side effects associated with them like a pharmacological therapy would. Be sure that the patient understands what may occur when they take their meds and what to look out for in terms of what needs to be reported to the doctor. In summary, it's important to emphasize lifestyle modifications whenever possible. These changes can be extremely helpful in preventing falls and fractures. Remember that patients should really stop smoking whenever possible, and they need to adhere to the recommended alcohol and caffeine consumption guidelines. Remember that usually they're saying in the AAC guidelines not to exceed 2 servings of either caffeine or alcohol per day, But if there's another disease state like dyslipidemia that requires a lower alcohol consumption recommendation, make sure that you give patients that recommendation. If you have a female patient who has dyslipidemia and osteoporosis, tell her not to exceed one drink, because you don't want to make the dyslipidemia worse by telling the patient that they can have technically 2 drinks, because 2 drinks is the cutoff for women in osteoporosis. But when there's another condition going on, make sure you give them the most conservative consumption recommendation. Also, emphasize the importance of regular exercise, because it can strengthen muscles and lead to less weakness and a lower fall risk. Patients should always be screened when the provider recommends it, so that signs of osteoporosis can be identified as early as possible. Be sure to emphasize to patients how to prevent falls, such as using non-slip shoes, carpet or rug anchors, standing slowly, sitting when dizzy, avoiding walking after taking sedating medications, things like that. Our first-line therapy for osteoporosis will be a bisphosphonate, but remember that denosumab is recommended in patients who have a very high fracture risk. Here are my references. If you have any questions, please write them down so that we can discuss them in class. Be sure to submit your lecture questions that I've had throughout the presentation as your lecture question evaluation 4. Put those on Canvas by Tuesday night and keep your answers with you during the next class so that we can go over them. Have a great day.